Our first speaker today is, get to the right page, Daphne Hernandez. She's an associate professor and the Lee and Joseph Jamil Distinguished Professor at the University of Texas Health Science Center at Houston in the School of Nursing. She is a developmental psychologist who has extensive experience studying health disparities resulting from poverty-related experiences, including food, housing, and food and housing insecurity. So, Dr. Hernandez, would you like to come to the podium, please?
I would first like to start off by thanking the organizers for inviting me to speak on the topic of population health, which is close to my heart. Population health and health disparities is what I focus on. Before I get into the main gist of my talk, I would like to explain how I got into population health. As a graduate student, I spent many, many long hours cleaning data for the Welfare Children and Families 3-City study. I also took an extraordinary amount of statistical classes at my institution and at other institutions. And then for my dissertation, I worked on the NLSY 97. Through my postdoc and then early in my career, I worked on the other data sets that are listed. Unfortunately, a number of these data sets I think are no longer available due to changes in the current administration. But the data set that is still available is the Future of Families and Child Wellbeing Study. If you would like to access that data set, you can scan the QR code. But this study has been around for 25 years. I've worked on it since the birth cohort, and it's really funny that it's 25 years because I'm only 25. So, yes, I started working on it at the age of 0. So today I'm going to be talking about how you build trust when working on large-scale studies and you don't have access to talk to a number of individuals. And I'm using the Health Outcomes Post-Eviction Moratorium, which is my R01 study funded by NINR. This project has a number of collaborators in the School of Nursing, along with the School of Public Health, UC Berkeley, and UT Austin. So this project evolved from the pandemic. During the pandemic, there was the eviction moratorium, and these were short-term housing interventions designed to limit the spread of COVID-19 and to maintain housing instability. The research out there does indicate that it did that, and it also reduced mental health problems. But as you may have heard, since then, there's been many economic disruptions that have occurred, especially in the area of food, shelter, and transportation. I'm pretty sure you've heard about the cost of eggs. And this week, we had the luxury of hearing about the start and stop of tariffs. And so all of these economic disruptions affect the most vulnerable of renters, which are individuals, most vulnerable renters who are at risk for eviction, who happen to be Black, Hispanic, and female tenants. So the overarching aim of the study, of the HOPE-M study, is to examine individuals that were exposed to this policy during the pandemic, and we're interested in seeing how they're doing with their mental health post-moratorium. We picked tenants in Harris County and Travis County because of the differences in policy that occurred in these two counties. Harris County did not have a local moratorium. It only depended on the state moratorium, which is very short-lived. And the moment the state moratorium got lifted, there was an increase in eviction filings. Travis County benefited not only from the state moratorium, but also the local moratorium. And their eviction filings stayed low until January 2022, when their moratorium was lifted and eviction filings went up. So if we compare eviction filings from 2022 to 2021, we see a significant increase in both counties. So how did we select our sample for our project? We were interested in tenants, again, in Travis and Harris County, and we used 2 sources of data. Our contribution to the literature is that we use actual court records. So we were able to get court records that state whether the individual was evicted or not. And we selected the time period from the moment the eviction moratorium was lifted through December 2023 for both counties. However, court eviction filings do not get to another group of individuals that are highly at risk for eviction. And those are individuals who may be threatened with eviction filings, but are never formally removed from their apartment or home. And so we use machine learning techniques to get access to neighborhoods that have individuals with the highest risk of precarity. So through our sample selection process, we started with over 37,000 cases. And then when we removed the duplicates, we began with over 32,000 cases. So this should be simple, right? We have 32,000 cases. Our wonderful statistician said we only need 2,000 cases to conduct our research. This should be a slam dunk. I should be done in a month. I can go take a vacation. But we have to remember this is a vulnerable population. This is a transient population. This is a population that changes cell phones month by month. It's a hard to reach population. However, we started with recruiting individuals through mailings, and the mailing had everything that you really needed. It had linked to the online survey. It had a description of the compensation that you would receive once you completed the survey, and it had a sheet of frequently asked questions. All materials were in English and Spanish, including the survey. As we started the project, 9 weeks in, we were only, so that's really hard to see, I apologize. We had only received about 400 responses. This was taking a long time. So when I looked at the change over time, starting from week 3 to week 9, I noticed that we were only getting 20 to 40 responses per week, which is crazy considering the other outreach that I'll discuss that we did throughout the weeks to increase responses. So then I sat with a survey company. We thought about what our different options are. And so we decided in week 10, we would revise the mailing to simplify the information on the mailing, make it easier to read, and also include a non-contingent $1 bill in all the mailings. Okay, so this differs from my community-based research where I'm able to go into the community, speak with participants in English or Spanish, and get them excited about a project. When you're doing large-scale population health surveys, it's really hard to do that. I mean, you just don't have the opportunity. So we included a non-contingent $1 physical dollar in the mailing, which meant we redid all our mailings. So this is around 20 to 30,000 mailings that went out again, plus close to $30,000 in $1 bills that went out in each of the mailings. So in week 10, we had basically 400 responses. Week 11, we increased our responses by 500. If you want to read about non-contingent $1 incentives or just non-contingent incentives, I have a QR code that links to readings, and there's other readings about other stuff that I'm talking about through the QR code. But non-contingent incentives are used to increase response rates, especially among hard-to-serve populations. The survey company actually got many calls after we did this, thanking them for including the dollar. So this is a population that is constantly scammed, didn't believe our survey was real, despite having logos from UTHealth, UT Austin, the other schools. It just wasn't believable that we would actually give them money to do a survey, right? So this made it, this increased our trust with the population. By week 19, we were able to get 1,818 participants in our study. So this is a little bit less than 2,000, but I was okay with this after the struggle bus occurred. So this was a response rate of close to 6%, which is low, but eviction studies have low response rates, anywhere between 5 and 8%. So I was thrilled. Another thing that we did, and it was too difficult to try to include all this information in one slide, is that we also, we, meaning the survey company, implemented emails, text message, and phone calls throughout. And something that I would like to emphasize is we need to stop telling our graduate students that you only do 3 calls and then you call it a day. When you're working with hard to reach populations, you need to do more than 3 calls. They're not going to put our survey at the top of their list when they're afraid of losing their house, don't know how they're going to get food, and don't have diapers for their child. You need to be in constant communication when doing large scale studies in order for them to put our survey at the top of their list. So it was a lot of community, a lot of outreach that we did in order to increase these response rates. We did the same I'm going backwards, sorry. We did the same methodology for the time 2 survey. So we started with 1,818 respondents. At the end of the data collection at time 2, we had an 83 response rate. So we had 1,512 participants from time 1 participate in the time 2 survey. And currently we have a number of working papers and many more to go. So how do you do smaller scale? So now that we've done this large scale study, a survey with a lot of people, how do we get them interested in talking to us, right? So we haven't talked to them. It's all been connected through a survey company, but now we want to do qualitative interviews. How do we get them to talk to the ivory tower? So we received a supplement to focus on the at-risk group, right? So we had a group that was formally evicted and a group that was at risk for eviction. And so through the survey data, we're able to actually do a little bit more finite and divide this group into 2 groups. And so we wanted to learn more about this at-risk group and their mental health. And so we implemented an explanatory sequential design. If you're submitting a grant, graduate students, please, 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 please include the design of your study in your grant proposals. It will help you. It will help you get funded, and it will help you just design a better study. So what this means, this type of design is we did the survey, and then we looked at the survey results and realized that we needed to understand more. We needed further explanation on this at-risk group. And so we did qualitative data, some qualitative data. My favorite type of qualitative data is photo elicitation, which involves asking participants to provide you with 5 pictures on a particular topic. And then the photos are used as part of the interview process. The photos and the actual data, the quotes, all become part of the analysis. But to tell you the truth, it's really hard to get individuals to give you pictures of the most vulnerable situations. So how do I get people interested in giving me these photos? I keep going the wrong direction. Okay, so what do? I conduct focus groups first. So they get to know us, we get to know them. They see that we're normal human beings. And then right after the focus group, I recruit them to participate in a photo elicitation interview the following week. When you back up the interviews right away, they're more likely to participate. The focus group helps to build trust for them to then provide you these photographs. I've been successful in implementing this method, received an 82% response rate in a previous study. When we did it on the current study, I had a 92 response rate. So 92% of the individuals that participated in the focus group also participated in the photo elicitation interviews. I would like to thank January Advisors for the extraction of the eviction records, M. Davis for the survey data collection and gift card distribution, NINR for funding the study, and to numerous individuals in the School of Nursing along with SPA for helping with everything that goes on with a grant proposal.
Thank you so much, Dr. Hernandez. What a great way to kick off the population health across UTHealth Houston. Okay, I have my glasses now, so now I can read. I'd like to introduce Dr. Sandy McKay. She's an associate professor in the Department of Pediatrics at McGovern Medical School, UTHealth Houston. She also serves as the Division Chief of Community and General Pediatrics and is a non-resident fellow at the Center for Health and Biosciences Baker Institute for Public Policy at Rice University. You can read more about her background in the program. Her research and advocacy work focuses on injury prevention, firearm safety, and health policy.
So I'm really grateful for the opportunity to be able to come here today to speak with you guys about our pediatric population health initiative that we have been working on within the Department of Pediatrics. And wanted to spend a little bit of time today talking about how our program developed and feature a few of our programs here. I know later today, some of our other programs will be featured as well, so I'm not going to talk specifically about those. But what we have is a group of really amazing people that came together, focused around the mission of how do we make children's lives better here in our area. And that is really what has been our core tenet. That's where we've been focused on. And we are a mission-driven team. And I think that's really where the magic happens with us. And that's really what has helped us be successful over the years, is that we just all really care about kids. And I think it sounds a little bit corny at times, but we're pediatricians, we're public health researchers, and that's what helps gets us through the day. And so you can see here, we have a really diverse team. And I think what helps us with that mission focus is that we really focus on projects that we're passionate about. And being someone who is focused in advocacy, that's what I teach my my trainees and my learners, is that the best advocacy comes about what you care about, right? So let's start with a project that you care about. And so what you can see is that our team has just a really bright group of shiny faces. And I always like to feature our team members. And you can see the really secret sauce, I think, to our team when we really started setting it up was we combined diverse sets of folks. So you'll see here that there's a lot of folks that are from not only the Department of Pediatrics, but we integrated people from the School of Public Health, from School of Nursing. We reached across people everywhere and just said, we have open doors. We don't care where you come from. Do you care about kids? Check. That's really our only criteria. We included trainees. Our very first Duncan Scholar was Malika Mathur, who started with us as a graduate research assistant. Now she's our postdoctoral candidate here, or postdoctoral scholar here with us, and we're really excited. And we also have our program manager, Tiffany, who makes all the magic happen with us. And where we started with us was we started in 2021 with a brainstorming retreat where we just came together and said, what are the core areas that we want to focus on? And we knew we wanted to focus on social determinants of health or non-medical drivers of health, nutrition, engaging in those community resources, and also how we can move forward with school health and engaging with communities. And what that really helped us do was identify like, hey, we needed some support. And that's where, getting that first Duncan Scholar was critical. And then we started moving forward with getting some initial funding in our area of injury prevention. I mean, that's my area of passion. So it was really easy for me to say, let's move forward with injury prevention work as well. And we were able to be critical in some of those areas. And getting that first initial support was important for us. And then also working on some projects around nutrition education, working and collaborating with community-based organizations such as Brighter Bites, which we do have a poster about that as well today. And then working with our non-medical drivers for health projects and launching them. And then really our amplifications took off between 2022 and 2023, where we started disseminating our success. And that was not only with local conferences, but also regional and national work as well. And then we received funding from Episcopal Health Foundation. That was kind of we really felt kind of excited about that and getting some longitudinal funding from there to really solidify the work that we're doing, not only and also to expand our work as well. And then I kind of think about like the explosion part here. All of a sudden we were like, what is happening to our world? Because, with a little bit of data and a little bit of pilot work, we started having this like snowball effect of success. And we started getting funding in a lot of different areas of support. And it really kind of solidified us there on the national scene. And we were able to expand our staffing and expand all of our resources as well. And so we are kind of moving onward. And I just kind of like when we meet with the team, we're just like, yeah, we're just keeping going. And even like earlier today, I was sitting with Andrea and we're like, let's write another grant. And we're sketching out the grant during breakfast. Like, all right, let's put that in. And that's just kind of how our team goes. We just get passionate about our work and we're constantly thinking about how we can integrate and bring in other schools. So this is a list of our active projects that we have right now. And I wanted to just feature this list as this is just not for you to read every single project, but more to know that we're busy because we like to keep busy. And, you know, my grandma used to say, you'll sleep when you're dead. So this is kind of like how I live my life. Like we just busy, we just roll all the time, you know, but that's just because we have a lot of passionate members and also because our team we want to loop people in. We see like, oh, that's an opportunity for a project. Let's see how we can work on that project. Yes, we've got some data sets. You're interested in it? Let's move. Let's see how we can make that happen. And let's see how we can disseminate that. So for 2024 alone, we had a total of 75 various types of abstracts, publications, presentations, manuscripts. So we're academically productive as well, because I'm always at the attitude of, if we did it, we need to disseminate it. So we're constantly pushing. So far to date, we've had over 200 scholarly works that have been published or disseminated at some level. From a funding perspective, since we've been in our inception, this is just a schematic of what our funding has looked like over time. We've been a tiny bit successful in various funding sources. So to date, we are just shy of 15 million in total awards, which has been really exciting for the various projects that we've been on. And I like this because it shows kind of not only the timeline that we've been working on, but we've had a lot of smaller pilot funding that's been awarded to us as well. And I think that's really been really important for us more than anything. So the 6,000, the 30,000s, the 10,000s, what those do for us is they give us that pilot funding, right? So we can gather quick little bits of data where we need it. And then what that does is that launches us into applying for those bigger R awards or those multi-year grants. And that's really where we can then capture some of that larger NIH data or that larger foundation data that's been able to get us the larger award. So moving into a quick highlight of some of the projects that we're currently looking at. This is one of our biggest awards here. This is our Houston HVIP program. This is a little over $6 million award that we have. It's a UG3 UH3 model. And right now we are going into putting in our transition package to go into the H phase, where we are establishing and evaluating a hospital-based violence intervention program for Memorial Hermann Hospital. And so we have developed a community advisory board taking a community-based approach to violence intervention in our community. And we have developed this as an RCT model, where we are doing the difference between the intervention program and an enhanced usual care arm. And we've also created a trauma-informed care curricula for the hospital that has already been developed, implemented, and now we're evaluating the results of that. So this is a really exciting program for us, and we're hoping our transition packet goes successfully, which it will because we've met all of our milestones. Yay, super exciting. And this is really important because one, we don't have an HVIP with our hospital right now. This is focused exclusively on gunshot wounds. When we talk to other centers that do HVIP work, they are shocked because in our pilot program, we had more gunshot wound victims present to our hospital than most other hospitals had present to their hospitals in a year. So our pilot ran for 3 months and they had not seen that many gunshot wounds in a year's time. So we have a lot of volume, which allows us to do really cool things like these types of programs. So more to come in the future on that. This program here is kind of my baby. This is the one that brought me my very first grant, I will say, like many moons ago before the Population Health Initiative was kind of like just starting, which is how do we talk to firearm owners about secure storage? So this brought me down the road of how do we do culturally sensitive, informed firearm safe storage counseling within the clinical setting. So I received some smaller grant funding that then led to larger award that is part of our Violence and Injury Prevention Center grant from the CDC, which creates a statewide coalition, which has now been meeting for over a year and developed informed secure storage education program, which is going to be tested and implemented in both the healthcare and firearm retailer space. This is a mock-up of part of our materials that we have developed and formed with a graphic designer on how we can facilitate the conversations in various spaces. So super cool work that we've been doing. So other things that we have been working on is we've created a trauma dashboard. So this has been led by Dr. Kevin Ricks, and he has taken the data that we have from our hospitals on traumas from our trauma registry and created into an interactive dashboard. So that way we can see at any moment what type of injury, where did it come from, frequency of injuries, and get all the demographics. This is super helpful for us because we also have a huge community arm that we do with our work as far as distribution of car seats, community interventions like hosting events. Next weekend, we're hosting a drowning prevention event in the community. So how do we know how to do these interventions, where to do these interventions? We can now make a more informed approach on this so that our community events can be guided in this way. We also have an NIH-funded grant called Aim Ahead. It's through a funder through the NIH is called Aim Ahead. And what this is really cool because I'm not going to talk about our social determinants of health work because you're going to hear about that later. But this takes the data that we have from our social determinants of health screener and marries it with the work that's being done on no-show predictors. So as you know, there's a lot of AI models that are out there trying to predict whether or not a patient is going to show up to their visit on time or not. And so what we are doing with this work is taking the massive data sets that we have with our current screeners that we use for our patients around their non-medical drivers for health and saying, can we develop a better predictor model? And can that predictor model say, how does the patient's potentially modifiable risk factors overlay with that no-show predictor model? And can we make a better model so that then we can identify potential modifiable risk factors that then we can recommend better solutions and potential policy solutions. Cool thing about this grant is not only is it with medical school of biomedical informatics, and also the Baker Institute for Public Policy. So bringing together more people. So you're going to see a lot of data coming out of this as well. And then finally, probably one of my favorite projects. So just because it's just a really fun project, is Futbolito for All and how we can improve active lifestyles for children. And so this is a collaboration between UT, Baker Institute, and the Houston Dynamo. And this is a really fun project. So what this is bringing soccer to vulnerable youth in the Galena Park ISD. So Galena Park, if you're not familiar with them, is an area that has a relatively high Latino population. And what they are looking at is implementing a program called Futbolito, which is already currently run by the Houston Dynamo, where they bring 5-week soccer programming to children. And what we're doing is evaluating, putting this into schools that don't have it and evaluating this so that we can see how do schools take this up and incorporate a program that they don't currently have, and how we can see, can we put soccer sessions into schools, enroll children, how does that impact their long-term, their follow-up for physical activity? How do the schools integrate this? Can they take up soccer education? Can the coaches, professional coaches, teach this teachers? And can they sustain soccer education within their schools on a long-term basis as well? So this is a pilot program, and we hope to have this lead to a larger implementation program in the future. And it's also really amazing because kids get access to soccer, which is really fun too. So more to come on all those programs, and you're going to hear a lot more about outcomes from that in the future, I'm sure. But thank you.
Thank you so much, Dr. McKay. Okay, so next we have Mohammed Walji. He currently serves as professor and director of the Texas Center for Oral Healthcare Quality and Safety, and he holds the endowed chair in dental and informatics. He has joint appointments with the McWilliams School of Biomedical Informatics, where he's the professor and inaugural chair of the Department of Clinical and Health Informatics. Dr. Walji serves as a PI on studies funded by NIH and AHRQ that use informatics approaches for improving patient safety, quantifying dental diagnostic features, measuring dental quality, using mHealth to collect post-operative patient-reported outcomes, and designing interventions to reduce antibiotic prescribing by dentists. In addition, he leads a multi-institutional team that crafted the Big Mouth Dental Data Registry.
Great, thank you very much. And thank you very much for the invitation, Dr. Hernandez, and to the whole population health team. So it's my pleasure to talk a little bit about the work that we're doing at the Texas Center for Oral Healthcare Quality and Safety. So we have this big idea, and our big idea is that every single patient, especially here in Texas, should receive high-quality healthcare. And we define high quality as the same as what the IOM does: person-centered, safe, effective, timely, efficient, and equitable. And thinking about what Dr. Lakey kind of presented earlier, we don't do so well when it comes to oral healthcare in Texas, unfortunately. There are many reasons for that, but I bet if I was to ask you to put up your hand, how many of you had visited the dentist in the last year? If you're anything like the general population, it's probably going to be half, or maybe a little bit above or a little bit less than half of the people have visited a dentist. If I was to ask you how many of you have had tooth decay in your lifetime, probably most of you will have put up your hand, right? So oral health, there are some major diseases, dental caries and periodontal disease. They're some of the most prevalent chronic diseases that we have in the United States. And unfortunately, our healthcare system doesn't really think of them as part of the overall healthcare system. Dental is often seen as kind of an ancillary, less important service. So we're really hoping to change that. There's lots of evidence to suggest that oral healthcare is a very important condition. It does have manifestations beyond the mouth as well, which we're increasingly learning. So we have a four-pronged strategy, very similar to what I heard Dr. Sharma present earlier in her work. So we are very focused on infrastructure to begin with. We really need to have really good infrastructure. Once we have really good infrastructure, we can start doing things like measurement, right? Because we don't often know a lot about oral healthcare. So if we have systems to collect data, we can now start measuring them. Once we have measurement, now we know how big the problem is. And then we can use various approaches to develop solutions for that. So in the next few minutes, I want to just tell you a little bit about Big Mouth, which is one of our infrastructure projects. And then I want to tell you about a research project that we've been engaging in for the last 8 to 9 years on quality measurement as well. So Big Mouth is a large dental data repository that is available actually to all of you. If you're at UTHealth Houston, you can actually go ahead and access this data set. So it contains data from 17, actually we've just signed on our 18th dental institution across the United States. They send their data to us here at UTHealth Houston from their electronic health records, and we aggregate it together and we make it available to others to do population health and other type of research. It is partially de-identified, so we're able to adhere to some of the HIPAA issues. The great thing is that it's accessible, so you don't need to be a computer scientist or a database person. You can actually do some drag and drop queries, and then we have a whole process in terms of how you'd be able to access that data. So in terms of the growth, we started this database, we launched it actually in 2012. We were fortunate to receive a small National Library of Medicine resource development grant for 4 institutions. It was us, UTHealth Houston, Harvard, UCSF, and Tufts. And we were able to pilot and showcase that, yes, we can actually aggregate data. We can have the data governance frameworks to allow that. And then over the last 13 years or so, we've now grown it to about 6.5 million patients. And you can kind of see, we have patients across the United States. So it's a great resource that's available. So what type of data do we have in there? So if you know about electronic health record data, you can think about it as structured data and unstructured data, right? So we're kind of focusing on the low-hanging fruit, which is the structured data. Unstructured data is very, very important, but it's a little bit more challenging to deal with and a little bit harder to get institutions to contribute that. So, we have information on the patient's demographics. Now, one thing when I'm not a dentist by training, so my background's in biomedical informatics. So when I joined the dental school 16, 17 years ago, when I started to look at this data, one of the surprising things is that there was no structured way of capturing a diagnosis. which is kind of strange, right? And so you have all these procedures, but there's no reason why these procedures were being done. So a group of us have developed a standardized dental diagnostic terminology, and it's now increasingly being used. So we have a very large number of patients with not only dental procedures, but the diagnoses associated with it. We've got all the history information, whether it's medical, dental history. The odontogram is basically the tooth chart. So when you go in to a dentist and they basically are able to say, which tooth has various types of findings. And then we have the periodontal chart, which is essentially the gums. So it's very multidimensional data, because when you go to a dentist and they start poking you, they're basically poking a tooth 6 times or around the site 6 times, and we collect all of those variables in our data set. So lots of data in there. So how can you get access to this? We have 3 levels of access. So right now you could scan that code and you're able to look at the public view. And so this is just a dashboard of the type of data that we have. So if you're interested in using Big Mouth for your own research purposes, you can look at that public view access. Here at UTHealth, because we are one of the contributing institutions, you can actually register for access as well and do some drag and drop queries. And so you can get access to the UTHealth Houston data, as well as data across the whole network as well. And then let's say you've identified a cohort that you think is interesting. Then we have a process that you can get access to the row level data, which we call controlled access. And there's a little bit of a process you have to go through where we have a project review committee. Members from every institution are part of that, and they kind of guide the investigator in terms of whether this is a suitable data set, how they can even improve their research project, and then we provide them that data for their analysis. So I highly encourage you to do that. So now, once we have infrastructure like that, we can do things like measure dental quality. So I want to just take you through a couple of quality measures that we have been focusing on. So this is all regarding tooth decay. So these are some things that we know are important. So if you're a dental practice, it's really important to classify the risk of the patient, whether at low, moderate, severe risk of dental caries. Because once you've done that, you can then determine what types of preventative treatment that are required. So if they're a child, we know there's lots of high quality evidence to seal the molars. If you're adults, you may be able to get fluoride. And so that's one of our caries appropriateness of care measure. So the first 3 are kind of, if you're familiar with quality measurement, they're process measures. And then the last 2 there, 4 and 5, are outcome measures. These are harder to measure. This is what's the health outcome on the patient. And we've been able to use electronic health record data to determine, whether a population of patients for a specific practice gets either new decay or if they have significant amount of untreated decay as well. So we have a partnership. We've been fortunate to be funded by NIDCR for the last several years. And we partner with another dental school, but we also partner with 2 large practices. One is a integrated medical dental practice in Minnesota. The other is a 50+ dental practice in the Pacific Northwest. And we kind of have come together as part of a learning consortium. We very much believe in this whole learning health systems approach. And we are running these measures. Some of them use EPIC, some of them use another EHR. So we're trying to develop these measures across a very diverse set of institutions, very different in how they practice, very different payment models, but we're trying to create tools to support all of those. So I'll tell you our UTHealth Houston is the orange circle there. So when we think about what percentage of our patients should get a risk assessment, it's about 2/3 of them. And you can see some of those practices are all the way up to 100%. When we think about, did the patients who have had a risk assessment, who are elevated risk, did they get the right preventative treatment, whatever that might be? Again, we're around 2/3, and you can see some of the other institutions are a little bit better. One of the surprising things that we've seen is for children, for sealants. Sealants in general, even though there's so much evidence, for some reason, only half or less than half of the children get their teeth sealed, essentially. So that's definitely an area for improvement to work on. And then, again, this is higher is better. So what percentage of patients have no tooth decay following follow-up? And we see a big disparity there as well across them. And then in terms of treatment, what percentage of patients have active decay? And so we still see a gap there. Again, higher is better. And so if you're interested in the measure specifications, there's a link there that you can look at. And so all of this has been published. Okay, so once we know what the magnitude of the problem is and we have a good, reliable, valid way of measuring it, we can now develop solutions to do this. And we use a human-centered design approach, and this is the model that we've adopted, and it's called the double diamond model. And you've got these two diamonds, essentially. The first diamond is really trying to define what the problem is. So, obviously we've got the measurement, but that gives us just partly the answer. We don't know why those 50% of the children are not getting their teeth sealed. What's the issue there? So now we can really dig it deep and dive into that. And every different practice may be slightly different. Once we know what the right problem is, we can then use a human-centered design process, very rapid, iterative prototype testing to kind of solve that problem. So again, because of time, I won't go through all of that, but I want to just show you some of the artifacts that we have from this. So on the top left here is what you see is a driver diagram. This is one of my favorite ways of thinking through what a problem is. So we've gone through this whole co-design process, and what we've identified is that there are 4 primary drivers that we want to influence in order to improve upon these quality measures. One is we need improvement in awareness and education for the dental professionals when it comes to why it's important to do risk assessment, what type of preventative treatment there are. We really need to standardize processes as well, and we heard that before about that before, right? Workflows, all of these things are becoming really important. Insurance and cost management, all the incentives that there are there also becomes important. And then lastly, we have monitoring and feedback. We need to be able to provide information back to the practices so they know where they are. So based on all of this and literally a year or 2 of work, our product is, and we're in the midst of developing this, is the caries management toolkit. And hopefully it takes a systems perspective. So it's not really focused just on that one individual provider, but we're looking at the whole system. So quality improvement 101, we need to train our clinicians to understand, why is it important? Why is this whole field important? We need to have really good technical specs so that clinics can actually run quality measures and they're reliable and valid. People can actually trust and believe that data. In the EHR, we need to have a risk assessment form. So we've developed a 6-question form that a clinician can quickly go through, and it gives them the risk of the patient. So based on that risk, we then need to have a protocol in terms of what should they be doing. And we've got an evidence-based protocol that we've done. Number 5 is audit and feedback dashboards. This is the idea that if we provide information back, whether it's to a clinic administrator, whether it's to the actual practice or the dentist, they're able to see how well they're performing compared to their peers as well. Number 6 is patients, right? We also need to include patients as part of this. And then lastly is more of an institutional thing. We want to be able to give the institutions, where are they on a spectrum when it comes to quality improvement? Are they at level 1, level 2, or are they all the way up to level 5? So we're developing this whole concept of a maturity model that a clinic can benchmark themselves against. And this is just a screenshot of one of our provider level dashboards that we're giving. So provider can see where are they on this performance. So you can see this provider is only 37% of their patients get a risk assessment. They can see statistically they're a little bit of a low outlier on this. They can compare themselves against others. And the whole idea is once they have some information about their peers, can that be a nudge? Can that kind of influence them to try and hopefully do things a little bit differently as well? And then the next step, once we've developed this in the next 3 to 6 months, we're going to now pilot this at the 4 institutions to see what happens. So hopefully you have a sense of the importance of infrastructure. Infrastructure is available to all of us, and we'd love to be able to work with you if you have any interest in improving oral health or improve the oral healthcare process. We're really looking forward to working with you. So thank you.
Okay, we have a little bit of time for questions. I'll see if there's any questions from the audience, and if not, I have a few here. While people are thinking, Dr. Hernandez, I love the way you talked about your mixed methods approach of using quantitative and qualitative data. Can you tell us a little bit more about that and how you think it improved your understanding of what was happening?
Yeah. Especially with this study, when we looked at the at-risk group, from from a quantitative perspective, I was like, I'm not sure there's much difference. But once we started talking to them through the qualitative interviews, we're analyzing the data. There are some differences between the two groups. So I think the qualitative data provides an opportunity to get at mechanisms that we're just not really good at measuring through the quant data. So I highly encourage mixed methods, quant and qual, whenever possible, because it really does help gain a better understanding of what those differences are that you just can't get out of quant data. And I'm a quant person, so but I partner with very skilled qualitative interview data people that are trained to analyze the data. So.
Thank you. And if you don't want to go to the mic, we can bring the mic to you. Okay, there's a question over here.
Dr. McKay, very impressed with the number of grants your group received. Do you have a lot of staff support? And can we take a picture of that? Some of
the staff
those
support
seems
money.
like they're not, they come from foundations that are maybe not very specific to medicine.
Yeah, so that's a great question. So we got our first program manager about 2 years into it. A lot of our support, I will say, comes from my department chair. So I really appreciate Dr. Aiken and all of her support to launch our pediatric population health initiative. We do rely heavy on our postdoctoral our postdoctorals. So we've got Kiana and Malika that are both here. I think Malika really I relied on her for so long. Like that. So our staff right now is we've got Tiffany, and then we've got Malika and Kiana, and they pretty much are our population health team, and then the staff that we hire from within our grants. So like our HVIP grant does have a full-time program manager dedicated to that we funded from the grant. And then we have a full-time injury prevention coordinator for our injury prevention efforts. So that's our staff. So we run lean, but that's where we are. But also we have, our team is set up to where every like PI, most of our grants have co-leads with them. So like we have a PI that's from like medicine side, like a clinician side, and then also someone who's from like either school of public health or from our HTI team. So there's co-writing that's involved. Our Brighter Bites initiative, which is a grant that is led with that. So usually when we get a big grant for a project specific, then that has staff that supports that grant, that's written into that grant. But as far as writing the grant, a lot of that is taken on up front, by the PIs, and then we get help and support, within the infrastructure that's built into what was our GRAs that are now our postdocs. So we've worked really hard to be successful within our grant infrastructure. And I think that's one of the things that I'm always looking for is how can I look at building a stronger infrastructure so that we can be even more impressive? Because I think we've been okay with what we've been, how we've been able to make this work. And I recognize that our team has put in a lot of work and a lot of long hours to reach the success that we have. And I think that, if we had even more infrastructure support, we probably could, as Buzz Lightyear would say, to infinity and beyond, right?
And I'll just follow up on that question, Dr. McKay. I think in many ways, the Pediatric Population Health Initiative is really a model for involving and collaborating across schools and centers. And I'm wondering if you could just sort of give advice, one, about how do you do that? Because a lot of times, we always hear about silos, and then when we hear such a success story of something that is not a silo, want to hear more about that.
Yeah, I think one of the things that we really value is the networking. Okay. And I think, I like to say that our team is like the anti-silo team. We really work hard on ensuring that we have quarterly meetings, that we are aggressive on inviting as many people as we can to quarterly meetings, pick times that are amenable to all the different schools. So it's a scheduling logistics nightmare when you think about, okay, well, we want to have it in May. Oh, wait, SBMI's graduation here, school of public health's graduation here. So we're constantly trying to be thoughtful about not just School of Medicine. And I think that's one thing that you have to be really intentional about, right? Because it's easy to be siloed. It's easy just to think about School of Medicine or Department of Pediatrics. So when you have to think about intentionally looking at all the schools, that's when you can start really improving your networking game. And then also not being afraid to start inviting yourself to other people's meetings. I'm really good at just inviting myself to other people's stuff and just not caring, and just being outgoing and taking the colleagues with you, right? And I think my biggest challenge to everybody here is thinking about your colleagues and saying, hey, I'm going to go to this meeting. I want you to come along with me, and bringing them along, because that's how you expand your networking game. And that's where you start saying, oh, I know you do this work. Don't you do this work? And it's the networking reception that we're going to have later, and say, I hear you like AI. How can we do AI in your stuff? You know, and promoting those conversations that you have over a glass of wine after work, and making that become a grant, and say, let's write that up, and sending that follow-up email the next day, and not letting time pass. And that's really where most of our grants have come from, has been a casual conversation about something that we've had in a hallway, and me kind of pushing the other faculty to say, you need to follow up on that with somebody. And like, oh, I think I know somebody over at SBMI. I think they can help us. And just pushing those conversations.
Great, thank you. Well, you heard her, so invite yourself to her meetings.
You're all welcome.
Dr. Walji, that was really fascinating, the infrastructure that you're building. And what struck me was you talked about these other dental practices, systems that are learning health systems. And I'm wondering about our own practice, and if you see it moving in that direction, and what potential you see there.
Yeah, no, definitely. So I really hope we can. And I don't think I've actually found another institution, at least in the dental side, that is a learning health system. We're all aspiring to be one, but it's very difficult to understand what that actually is and how do we do that. You know, so it's nice within the dental community that there are these institutions that are willing to share the data, the knowledge, the collaborations, so that we can kind of get there together. And I'm hoping here, you know, at UTHealth as well. I know there are initiatives in place to do that. One thing we're excited about from the dental side is that we're hoping that there's going to be a clinic over at Bel Air Station, UT Physicians, where there'll be a dental clinic now as part of, you know, all the other medical clinics. And so that's a great opportunity for what's called care convergence. You know, how can we, you know, look at a patient holistically? So if a patient has diabetes, maybe, you know, we should really get them seen by the dentist, because we know there's a link between periodontal disease and diabetes. And maybe if you treat the periodontal disease, that might actually even improve some of the values when it comes to diabetes. So hopefully there's lots of opportunities there. There's also opportunities to learn and to do research, right? Because that's the purpose of the learning health system. So if we can collect data and, you know, contribute to the evidence, that's just a win for everyone.
Fantastic. Any other questions? Okay. Thank you so much. This has been really phenomenal. And I think that one of the goals of the Office of Population Health and our efforts at the institution-wide is to create more initiatives like the one that you talked about, Sandy, more opportunities to create learning health systems and opportunities to build upon collaborations across the schools. So if you all have interest in a particular area, for example, you heard somebody talk, begin to talk about that. Begin to talk about how can we work together to collaborate across schools and like you said, to infinity and beyond. And our office is very happy to help coordinate that and to support it in any way we can.